This is my newborn assessment. I'm going to start by just addressing some general things with our newborn assessment. First, you're going to weigh your infant. So you would take them to a scale and you would place a cloth in between them and the scale just to keep them warm so they won't lose any heat. During this time, you can check for the posture by extending the patient as much as possible. And while you're checking for posture, you can also measure the infant as well. If the infant is calm, you can take their respiratory rate here, as well as you can get initial pulses from the infant by assessing their brachial and femoral arteries. Also, you can look for involuntary and voluntary movement of the patient, just assess for muscle tone. Throughout this assessment, I will be pointing out different skin assessments as we go along. So first, I would like to start by assessing the head and working our way down. So first, I would measure the circumference of the head at the fullest point. So we would do that and document. And then we would fill the front nails at the top of the head and move our way down. The anterior front nail should feel flat and firm and soft, and as you move down, possibly, you can feel pulsations, which are normal. And once you get to the posterior front nail, which you should feel a diamond shape. You are checking for molding, caput, and cerebral hematomas across the suture lines. Once you have assessed the top of the head, you can also, during this time, you can take note of the hair. So once we have done that, we can look at the eyes and the facial structure and just make sure everything is symmetrical from side to side. You observe skin coloration, so see if the patient has any stork bites or any abnormalities of the face. So we would just look at it. Sometimes you might see, you do not want to see any cyanosis of the actual lips. So then we will go to the actual eye and check the color of the eye. You would also check the sclera. And like our object here, you might have some edema around the eyes, and that is common just through birth trauma, and that the patient has slight edema. So then you want to rule out strabismus, you want to test the reflex of the cornea and assess for the retraction. And you want to see if the light hits at both spots of the eye to rule out strabismus. So now we have assessed our eyes. We're going to move to the ears. Our object does not have any ears here, but we're going to imagine that we're drawing a line to the ears, and we would go about here. With this, we would assess if they align with one another, and we also can feel the actual consistency of the ear to see if it's firm, if it's movable slightly. So we want to definitely do that. Then we can also make a loud clapping noise to assess the actual hearing and reflex of the baby, other reflexes of the baby. So once we do this, we would move back to the center of the face and check the nose. And we would just want to see if both nostrils are symmetrical. Then we would definitely check patency and breathing. So you want to cover one nostril, and you would make sure your chest is visible to you so that you can, since babies are chest breathers. So you will cover and let the patient breathe. Then you cover the other nostril and let the patient breathe. So we have done that. Now we will move to our oral cavity. Since our patient's mouth is closed, I'll be describing what would occur. So here we would be assessing the patient. We would be assessing the patient's soft, hard palate, and we also assess the movement of their tongue, and we assess for eps and pearls. The best method would have your infant crying so you can get a nice visual view of the structures within the oral cavity of your patient. and so that she can feel around. Also, you can, since you were, you would want to see Epstein's pearls, which have a white pus-like consistency in the mouth. And then you would also check the movement of the tongue there, and then you would use your fingers and check the upper part to check the soft and hard palate. So once that is done, during this assessment too, while you are checking for the hard and soft palate, and you are at the mouth, you can assess for the sucking reflex, and by stroking the sides, you can check for the rooting reflex too. So now we're going to move to the neck / upper chest area. So you want to palpate for the trachea is midline, and then you would go outward and assess for the clavicle to see if it's straight, which is normal, and you want to see if there is the clavicle is not fractured. Now we want to move outwards to chest muscle tone of the upper body. So now that we're assessing the muscle tone of the upper body, and we move outwards, we will look at the hand, you would count the actual digits, and then while you're counting, if you feel necessary, you can do capillary refill with your infants. You want to check the palm here too, and you want to see if assess the folds in the hand as well, to see how the numbers and the amount of folds in the hand, to see if they're normal. Then you would move back into closer to the body and right about here, and you would assess the brachial artery, and you would do this for a full minute. So once you have done that and assessed for the brachial and got your pulse, you can also feel for tegor of the skin, just to assess for dehydration. So now that we have done that, we're going to grab our stethoscope, and we are going to listen for our lung sounds for our infant, and we are going to listen for our heart sounds. So you want to start about up the upper chest area, right about here, and you're going to listen for lung sounds. You want to make sure that they're clear and there's no fluid remaining from when the infant was in the womb that was not suctioned before. And we'll go to the other side here. And once we have assessed our lung sounds, we would want to go to the heart, and we would feel for the intercostal, which is usually right about here in this section right here. So we're going to place our stethoscope right there, and we're going to listen for a full minute. During this time, it is normal to hear a heart murmur with your infant. So, and that will diminish over time. So once we have done that, we're going to go ahead and listen for our bowel sounds. Since we still have our stethoscope, we should just go ahead and do it. And we're going to use a clockwork formation. And we're going to do this visually in each quadrant. Okay, so we have done that. Now we are going to look at your infant. You can look at your infant and see if there is any afrocyanosis, since you have a nice a big visual field of your infant. And then you would want to look at the center and look at the umbilical cord here. You'll want to see if the umbilical cord has three veins, 2 arteries, and 1. Let me repeat that. 3 vessels, 2 arteries, and 1 vein. Then we would go ahead and palpate. And while we're palpating, we'll be feeling for certain organ development here. And we want to document. You should be able to feel the stomach, the spleen, and if the patient is really relaxed, you can possibly feel the kidneys. And you want to take note of the breast area and the nipple area of the infant, and measure that. Even though it might be enlarged, you still want to measure that and take note of the enlargement of the infant's breast. It is normal for them to have enlargement due to the hormones of the mother. So now we have done that, we would want to move to the lower extremities. So you're going to palpate here and just assess for muscle tone once again. Then we're going to look at the foot, count the toes here, and then you can do strabismus by stroking the strabismus reflex by stroking the sole of the foot and going down in a seven pattern and stroking down to assess the reflex, so the patient toes should curl up. So once we have done that, we can move back up and we can take the femoral artery pulse. We have done that. Now we can go to the actual legs and we can assess to see if they are symmetrical. We could have did that before, just seeing they're symmetrical, but then we can also see if the knees are symmetrical. And why we are doing this in our patient is this position. We can do the Barlow test where we bring our knees inward and we will press down to test for dislocation. And then we can do our Orlani test where we go outwards and we would lift the hips of the infant up to get that, to attempt to get the patient to pull back in. So we have done that and tested our patient for dislocation. We would move to the genitalia area. So once we have moved to the genitalia, my patient obviously doesn't have any genitalia here. So we want to, if we want to overall, for both male and female, look at the overall structure just to see if there's any swelling. With a female, you might see swelling where the labia majora is covering the minor due to just normal hormones of the mother and the patient. And there's also, you might see some slight discharge that's like a white or bloody tinge, which is normal, a normal presence with the infant if it's a female. If it's a male, you want to see and test for the distension of the testicles. This usually occurs between 32 and 34 weeks of the infant. You also will want to look at the opening of the penis to assess that, and also assess the scrotum. And also with your male newborn, you would want to assess for the hemisteric reflex, whereby you stroke the side of the patient's thigh, and possibly the scrotum should react by pulling upward slightly, and that would be the indication of that reflex. So now we have done our front area assessment. We would turn to the back, and during this time you would have also just overall skin assessment. You would have checked to see if there's afrocyanosis. So now I'm going to take my patient and turn them to their backside. So now that I have done this, I would assess and palpate the vertebrae of my infant. Okay, we have done that. And you would palpate all the way down. Certain things that you would want to, that you might see, you can see further stroke bites for assessment. You might see Mongolian marks on the base of the patient's back too, as well. And as we go down, you want to assess the sacrum to see if it's fully closed.